Good afternoon, and thank you for joining our second webinar for the Scoliosis Research Society. We have a wonderful talks lined up for you today. We'll start off briefly with an introduction of the presentation, followed by a case presentation and a question and answer session. You're certainly welcome to send us questions throughout the talk, and we will try our best to answer the questions at the end of the talk. There will also be an opportunity to have questions sent electronically after the presentations, and those will be addressed answered up to a week after the presentation today. So the focus of the talk today is on operative treatment options for adolescent idiopathic scoliosis, which is one of the most common presentations for scoliosis. My name is Dr. Sanjeev Rothwala. I will be moderating the talk today, and we have three wonderful speakers. First off, we'll have Dr. Kevin Neal from Florida, followed by Dr. Ryan Goodwin from Cleveland, and Dr. Mark Lee from Connecticut. We will start off the presentation with Dr. Kevin Neal, who is an orthopedic surgeon at the Neal Children's Specialty Care Hospital and Chief of Pediatric Orthopedic Surgery at Wolfson Children's Hospital in Jacksonville, Florida. He will give us a talk on the review of natural history and operative indications for adolescent idiopathic scoliosis. So I'll have him continue. Thank you.
Okay, thank you, Sanjeev, and thank you to Scoliosis Research Society and its Patient Education Committee for putting this webinar together and for having me on today, and thanks to all of our attendees who may be live or who may be viewing this later recorded on our website or YouTube channel. So my task this morning is to talk to you about the natural history and basic operative indications for adolescent idiopathic scoliosis. Just a brief word about what we mean by natural history. What we mean by that is what's going to happen with a condition or a disease if we don't intervene and don't prescribe any treatment. And in medicine, there may be a lot of conditions that have a very favorable natural history and really don't require much intervention or treatment. And there may be other diseases or conditions that have a bad outcome if we don't do something about them. And idiopathic scoliosis can fall into both of those categories, as we'll see. Smaller idiopathic scoliosis has a very benign, favorable natural history, but it's less favorable when it gets larger. And so that's when we start talking about surgery. Let's talk about the definition of adolescent idiopathic scoliosis. So this is the most common type of scoliosis, and let's break it down by each word. Adolescent means that the condition gets started when you're age 10 or older, and it's a little bit arbitrary. Chronologic age may not be the best marker for when people quit being children and become adolescents, but basically why we break it down like this is we're trying to differentiate between people who get scoliosis at a much earlier age and people who get scoliosis when they're beginning to go through that adolescent growth spurt. And so age is easy to measure, and so we break it down as the scoliosis starting when you're age 10 or greater. Now, the word idiopathic means there's no underlying cause, or at least we don't know what causes it. And most people recognize the word because of the modern word idiot, and it's true that they both have the same root in Greek. But the medical use of it just means that the underlying cause or reason for the condition is currently unknown. Now, for this type of scoliosis, we have to say there's more and more evidence that it is a genetic condition. We know it runs in many families. There have been many genetic markers identified that are associated with it, but it's still hard for us to figure out. So even when it does run in families, it's difficult for us to figure out who's going to get it in the family. And even if you get it, it's hard for us to figure out who in the family is going to get a large one and who's going to get a small one. Now, in our lifetimes, we may figure this out better, and when we do that, we may change the name of the condition, but right now it still falls into the idiopathic category. The word scoliosis means a curvature of the spine, and the Scoliosis Research Society defines scoliosis as a curvature greater than 10 degrees. So you'll see a couple of x-rays on the slides here, and the angles are a little bit small, but if you go to the doctor and you get an x-ray to measure your scoliosis, they're going to draw these angles on the x-ray. These are called Cobb angles. And if the Cobb angle is greater than 10 degrees, we define it as having scoliosis. Now, a couple words about that. One is to keep in mind that these angles are easy to fudge a few degrees either way. And depending on how the patient is positioned for the x-ray, depending on even the time of day, what doctor is measuring it, the angles can change a little bit. And so we generally consider measurement error on the angles to be plus or minus 5 degrees. What that really means is if the doctor measures you with 10 degrees, it really means you have a curve in the back somewhere between 5 and 15 degrees. So the point of that is if you see a doctor many times to follow your scoliosis and the degrees just change a little bit, it's nothing to get super worried about. What we're really doing is following trends over time rather than those exact measurements. The other question is, well, why don't we call a curve less than 10 degrees the scoliosis? It's still a curve of the spine after all. And the reason for that is curves less than 10 degrees are very natural. In fact, it may be possible that nobody is really 0 degrees. We can probably measure a few degrees on one of these Cobb angles in almost everybody. And when we look at these x-rays that we're taking from the shoulders to the hips, we notice that people are just naturally asymmetric, so nobody is perfect. And when we look really closely, we'll notice almost everybody may have one shoulder that's a little higher than the other, or one hip that's a little higher than the other, and everybody has these very small degrees of curvature in their spine. And so we consider these small ones very natural and normal and nothing to worry about. So how many people have adolescent idiopathic scoliosis? Well, we're not completely sure, but the data basically comes from population studies where a large group of teenagers have been looked at and usually had x-rays, and then we can define how many people in the population have it. And the numbers differ a little bit between studies, but these are the basics. The first thing to know is to diagnose scoliosis, we usually do physical examinations first. So you're probably going to go to your regular doctor, or you're going to have a healthcare provider in your school look at your back, and that's done by having you bend over and assess for any asymmetry in your shoulder blades or asymmetry in your ribs or your muscles. And then sometimes they use a little device called a scoliometer, which is like a carpenter's level to measure the asymmetry. If there's any concern, usually an x-ray is ordered. Now here's the good news. If you get identified as having scoliosis just on this physical examination where you bend over, you really only have it about half the time, and that's just because the physical examination is not nearly as accurate as the x-ray. So if you get referred for a scoliosis x-ray, it's also nothing to lose sleep over because half the time you're not really going to have it. So in the population, these are the basic numbers. About 1 out of 50 people has a real scoliosis or a curve greater than 10 degrees. Now it's much less common to have a bigger curve. So a curve greater than 20 degrees only happens in about 1 out of 250 people, so that's a 5-fold difference. And then a curve greater than 30 degrees only happens in about 1 out of 500 people. And then really big curves, like greater than 50 degrees that we might start talking about operations on, we estimate that they're about 1 out of 1,000. So having scoliosis is about 1 out of 50, and needing surgery for scoliosis is about 1 out of 1,000. That's a 20-fold difference. So the good news there is that at 95% of patients who are diagnosed with adolescent idiopathic scoliosis are not going to get to that range where they need surgery. So scoliosis is more common in girls. When you have the small curves in your back, it's the same. And as we said before, it's very natural to have small curves in the back less than 10 degrees. So that ratio of boy to girl is 1 to 1. But as the curves get bigger, we start to see more of a prevalence in girls. And we don't know exactly why this is, but as I mentioned earlier, we're fairly sure this is a genetic condition, and so the chromosomes are obviously different between boys and girls. When we get to curves 11 to 20 degrees, the ratio becomes 1.4 girls for every 1 boy. When we get to curves greater than 20 degrees, it becomes 5.4 girls for every 1 boy. And then we get to the larger curves that need interventions like braces or surgery, it's 7 or 8 to 1. So why do some curves get larger? The two big factors that help us predict whether curves are going to get bigger are how big the curve is, so curve size, and growth remaining, okay? And these are kind of busy slides, and I don't want you to read all of them, but they're basically showing you the same thing. So on the left column, we have markers for how old you are, and then on the top, we have smaller curves and bigger curves. And just notice the circles. So smaller curves in older patients have a very low risk of worsening, and larger curves in younger patients have a much higher risk. Same thing here, smaller curves, older patients, low risk, larger curves, and younger patients, much higher risk. So if we have some risk of the curve worsening, how can we stop that? Well, bracing appears to be the most effective treatment for moderate scoliosis to keep the curves from worsening for select patients. So who are we going to use braces in? We're going to use braces in people that are still growing, perhaps not those that have too much growth remaining, but patients who are in that phase where they're going through the adolescent growth spurt. We're going to use it in moderate-sized curves. Usually we say about 20 degrees to 45 degrees. We're going to use it in patients who are willing to wear it because we know they don't do anything if they're not worn, and we also know that they have what we call a treatment effect, which means that the more hours you wear the brace, the more likely you are to not have surgery. Now, one thing I want to say is there are a lot of different brace types out there, and doctors definitely have their preferences for which ones work best. What we can say about it is that in general, bracing seems to be the most effective treatment. It's hard for us to break down further than that and say that there is one most effective brace. So my recommendation, if you are considering using a brace, is that you take your doctor's advice on the best brace for your scoliosis. So when is bracing not used? When is it not effective? So it's not as effective in very young patients who have so much growth remaining that their curvature is going to overcome the brace. Now, we still may use braces in those younger patients, but we have to be honest in those situations and say we may just be using it to delay the inevitable rather than prevent the curve from worsening. We don't use them in older patients who are not growing sufficiently anymore, and that's because they don't have enough growth left to alter the mechanics of the spine. We don't use them for certain curve types. For example, very high curves that we call proximal thoracic curves are up closer to the neck, and we really can't brace those areas effectively. And then we don't use them for really large curves. They're uncomfortable. It's difficult to get good in-brace correction in the first place, and they just don't seem to be as effective as they do in those more moderate-sized curves. A lot of people have questions about exercises for scoliosis. So and these are called scoliosis-specific exercises. If you go online and look, you can find a lot of practitioners who offer this sort of thing. The most common program is called the Schroth method, which was developed in Germany. And what scoliosis-specific exercises are basically you're using the muscles instead of a brace. So they're teaching you to do therapy exercises that use your own muscles to position your spine in a straighter position and try to hold it there. So basically the exercises are you using the muscles to actively correct your scoliosis, and braces are doing it for you. So we call that passive. The brace is doing the correction for you. Now, we have hope that this is helpful. We just really don't have good evidence yet, and so Scoliosis Research Society cannot really fully endorse it at this point. I think what we would say about it is that there are studies being done to see if exercises might be helpful treatments. We're just not sure yet. In general, they're not harmful. Most of us will allow you to do them, no problem, as long as you are also doing our recommended most effective treatment of bracing. And then the other thing we would say is just doing exercises or therapy in general is probably not helpful. So if you're going to try this, you need to see somebody that is trained to do actual scoliosis-specific exercises. So what happens when patients are done growing? And this graph is very simple. What we see on the bottom horizontal axis is how big the curve was when the patient stopped growing, and what we see on the vertical axis is how big the curve was years later. And so if it didn't change, it would be right along this line in the middle. And look at these two basic groups. So in patients that had a smaller curve when they were done growing, it didn't change, and it didn't get worse when they got older. But at larger degrees, and you see this cohort of patients where the curve continues to get bigger. And we don't know exactly why this happens, but it's possible that in the larger curves, after patients are done growing, there's still the effect of gravity, and we're able to resist that at the lower curves, but we can't overcome it at the larger curves. So basically, larger curves can progress after patients are done growing, but smaller curves tend not to progress after patients are done growing. So what does happen if the curve continues to progress? Well, the most important thing to know is it's not going to kill you, okay? Scoliosis does not create significant medical problems. It's true that some patients might experience a little bit more shortness of breath for really large curves, but that is generally not life or activity threatening. Patients may have more back pain when they get older, but even though they may have more back pain, most of them don't classify it as severe back pain that limits them. So there are no limitations even with really large scoliosis. It does not affect childbearing. That is about the pelvis, and it's not about the spine. And so what is the downside? So you can certainly live with a large scoliosis if you chose to do that. The downside is that as the curves get bigger, so do the bumps on the back. And they can get fairly large, and they can be a really significant cosmetic concern. And so it's unusual for people to tell us that they don't care if their curves continue to get bigger when they get older. Most people want to stop that process so that they're not having these bumps on their back continue to worsen over time. Can you advance that slide for me, please? I seem to have lost control. Thank you. So when do we recommend surgery? So we recommend surgery when patients have curves that are large enough that they already find them unacceptable, and when the curves are more likely than not to continue progressing, and patients don't want that to happen. So the most important thing to know about scoliosis surgery is that it is elective. Because it is not going to kill you, it is absolutely your choice to have scoliosis done, surgery done or not. Now, the most common threshold that we use for when curves are likely to progress after you're done growing is in the 45 to 50 degree range. So we usually say that curves lower than that, you have pretty good odds that it's not going to get worse as you get older, but curves larger than that, the risk goes up, and we think that the curves may get worse as you get older. So that's where we start talking about it. But we don't make you do it. So we do the surgery when you tell us, I already think the curve is too big, I don't like the way my back is, I want to make sure that it never gets worse when it gets older, and I want to have it straightened out.
Great. Thank you, Dr. Neal, for a wonderful introductory talk to scoliosis. We've received a lot of questions throughout the talk, and we're collating them. We will have the presentation at the end where all the questions will be answered. So thank you for your patience, and keep sending us those questions. Next up, we have Dr. Mark Lee, who is an associate professor of pediatric orthopedics at the University of Connecticut and Connecticut Children's Medical Center, and he will give us a talk on principles and history of surgical treatment for scoliosis. Thank you, Dr. Lee. Go ahead.
Thanks very much, Sanjeev. Today I'd like to talk about the principles and history of surgical treatment for scoliosis. So the goals of surgery are really threefold. The first is to correct the deformity, make essentially the curves better. The second is arthrodesis or fusion, and the third is safety. And these are the three components I'd like to talk about today. I think the first point of confusion I'd like to address is the idea of fusion. So in the cartoon to the right, you have a surgeon explaining to the patient, well, have you considered spinal fusion? And in the patient's mind, this is a nuclear event. So fusion is not so. Advance the slide, please. Understand that the spine is essentially a bunch of building blocks that are connected by very, very small joints. And the idea of fusion is to really eliminate all these small joints and connect all the building blocks one after the other. So if a fusion is successful, if your arthrodesis is successful, if you go back and look at the spine 3 years later and remove all the instrumentation, it should be one big layer or block of bone that goes from the top of the instrumentation all the way down to the bottom. Now, this is the lasting biologic effect of the surgery. This is what will maintain the correction that you got and prevent the curve from getting worse into the future. The earliest treatment for scoliosis is really offered by Hippocrates, and he described scoliosis, and he also proposed a form of treatment. And essentially, he said, "Oh, why don't we kind of put you on a rack and stretch you out, and then we'll have a muscular person sit on the prominence of your deformity." So this was this had kind of very, very variable success rates, and but this concept was extended to subsequent casting. So in the 1950s and 60s, casting became quite popular, and essentially a patient would be placed into a full body cast with the hopes of maintaining as well as correcting the scoliosis. The surgeons started realizing that arthrodesis was the main was the central component to maintaining the curve for the long run. So they combined both the surgery as well as the casting. In the pictures here, the surgeon would perform the arthrodesis procedure, and mind you, without any of the metal implants that we use today, would essentially scuff up the spine and wait for the spine to fuse together. The patient would also be placed into this long cast with a window in the back, and the window would allow you to take a look at the wound. And I always joke that the bar to the right of the patient was to facilitate transport for the parents of this particular patient. Now, Harrington came up with metal implants for the spine in the 1960s and 70s, and this was revolutionary. If you think about it, before this, it was really heresy to think about putting instrumentation or implants into the spine. But Harrington's contribution was that if you put a rod connecting the components of the scoliosis, and you use the rod to correct the spine, you really actually have some very good clinical results. In addition, the metal will hold the spine still while the fusion occurs, so it obviated the need for these rather cumbersome casts that were applied for about 6 months to 1 year. The surgical treatment was further advanced by Lukey, who suggested that, hey, instead of doing a single hook above and a single hook below with a rod, let's kind of put in a couple of rods and then attach the rods to every spine segment for greater control. And this particular construct allowed patients to do even without braces in the postoperative period. In the 1980s, Cottrell Dubuisset suggested, hey, why don't we use additional metal implants called hooks from the top of the construct and the bottom of the construct. And in addition to the hooks, we can use the rods to not only stabilize the spine, but can also correct the deformity through rotational maneuvers. And this is an X-ray of such a construct at that time. And from there, we have developments of what we use nowadays. 1990s to present, we typically use constructs that are made up of all these kind of things called pedicle screws, which are essentially fixation points that go from the back of the spine to the front of the spine. And they often look like the screws that you might kind of get from Home Depot or Lowe's, but they have a lot of research behind them and have really facilitated the surgery, essentially the ease and the speed of the surgery. An example of modern instrumentation nowadays is this 15-year-old boy with adolescent idiopathic scoliosis, and instrumentation looks kind of like this, with 2 rods and screws as well as hooks up above. The additional advances for spine surgery are multiple folds. And the first and probably the most important is this idea of spinal cord monitoring, that patients, when they're going through the surgery, have electrical cords and leads attached to their head as well as their legs to check in real time the function of the very important nerves, the communications from the brain to the legs. You understand that kind of these electric wires are essentially contained in the spinal canal. And when you're doing surgery to correct the scoliosis, sometimes these wires do not like being manipulated like that, and you can actually wake up with the possibility of having weakness in the legs or even paralysis. Being able to judge the function of these nerves in real time has tremendously increased the safety of this particular surgery. The surgeon will know, hey, these nerves don't like it, and we can take a step back. So overall neurologic complication rates have decreased to about 0.5% for this particular surgery. Additional advances are blood conservation. Spine surgery can often result in a large quantity of blood loss, and many advances have allowed not only saving or decreasing blood loss, but also increasing the safety of transfusion if you should need it. So we do things such as hypotensive anesthesia, meaning keeping the blood pressure low as the patient's receiving the surgery. We use blood recycling machines called a cell saver that takes the blood that's lost in the field and gives it back to you. We use better cauteries, essentially things that allow you to coagulate bleeding points in the soft tissues. We have recognized that it's very important to keep patient temperatures stable throughout the surgery to decrease the risk of blood loss. And we've also appreciated the risks of transfusion, that the screening processes needed to be better, and that blood should be quite safe for the patient at this point. Other advances in spine surgery include infection control, and the components of this include use of perioperative antibiotics, meaning that we give antibiotics to the patient before the surgery to decrease infection rates. We realize sterile prepping and draping is of the utmost importance and pay particular attention to this. We've also realized that the more people that walk around in the operating room and that are part of this operating room environment, the greater the risk of infection. In addition, we've started using intraoperative topical antibiotics, essentially antibiotics that are placed into the wound to decrease infection rates. Current infection rates for spine surgery are approximately 1%. So in summary, the goals of scoliosis surgery are to correct the deformity, to make the scoliosis better, to fuse the deformity, essentially to create a lasting construct that will prevent the curve from coming back, and thirdly, patient safety. Modern surgical advances have improved safety and efficacy through implant design, perioperative and intraoperative care, neuromonitoring, as well as new research and understanding of blood loss and its control.
Okay, great. Thank you, Dr. Lee, for a wonderful presentation and overview of the topic. Next, we have Dr. Ryan Goodwin, who is going to present on current concepts in surgical treatment. He is at the Center for Pediatric Orthopedics and Spine Deformity, Orthopedic and Rheumatology Institute at the Cleveland Clinic in Cleveland. Thank you, Dr. Goodwin. Go ahead, please.
Thank you, Sanjeev, and good morning again, everybody. This talk, my charge is to talk about current concepts in surgical treatment for adolescent idiopathic scoliosis, and I think it will piggyback nicely off of Dr. Lee's very nice talk for talking about how we go about performing surgery in 2017 for most of these cases. Most of the procedures that are done in 2017 are posterior procedures, meaning that the procedure is done through incision on the patient's back. And again, most, as you might expect, would have general anesthesia, and we oftentimes add some sort of adjunct for pain control afterwards, either an epidural catheter or some sort of intraspinal medicine or some sort of injectable medicine to help control pain afterwards. They're done in the prone position, which means the patient's face is down, which I'll show you in a couple slides along the way. And as Dr. Lee just pointed out, the invasive monitoring, the neurologic monitoring that we use for real-time feedback of the spinal cord function has really been remarkable in improving patient safety with these procedures. Again, here's sort of a cartoon example of what it might look like, but the patients, once they're asleep, are hooked up to basically a computer through these wires that are connecting the patient's head and their extremities, and they give real-time feedback to the motor pathways, which allow the brain to tell the muscles to move, and also the sensory pathways. So we get real-time feedback as to whether or not the spinal cord is happy throughout our surgery or not, and it allows us to make changes before there are problems. Here's another example of what it might look like. Here's usually a laptop computer in the operating room setting. And again, the incidence of a neurologic injury is really less than 1% in most of these cases. Here's what a positioning frame might look like. Patients are positioned on their abdomen. On the left side, there's some here called a Jackson table, and on the right side, something called a Hall frame, where the patient is positioned for surgery on their back, and allows their abdomen to be free. And it's important that we pad the patient's bony prominences around their pelvis their shoulders and chest and their thighs and knees. So pressure is at a minimum throughout the procedure. So walking you through the steps of what might happen, the first part of the procedure is usually exposing the spine and confirming which levels need to be instrumented and fused. And then we go ahead and apply these bone anchors, which we've already seen look largely these days in the form of pedicle screws, but it could be a hook or a wire or some sort of a band that allows us to basically control the spine. We'll then perform some sort of releases or osteotomies, which means cutting or removal of bone to help make the spine a bit more flexible. Then we'll go ahead and select the rods that we're going to use and contour them. They're manufactured, most of them are manufactured straight, and we have to contour them to an appropriate shape for each individual patient. Once that's done, we'll apply the rods to the bone anchors and get the correction. And ultimately, the bone graft infusion at the very end, where we sort of scuff the spine up and create a nice bed for the bones to all fuse together to maintain the lasting correction and position of the spine so those bumps don't get worse the rest of the patient's life. And once that's done, the closure. So here's what it might look like after spine exposure and confirming levels. You can see the patient's head would be to the left and their feet to the right. Next, we apply the bone anchors. Again, pedicle screws are the workhorse of our metal implants that get a hold of the, basically get a hold of the spine and allow us to control it and keep it where we need it to go. And it's done basically by making a small pilot hole over an appropriate anatomic landmark, and then we enter this little tube of bone and make sure that it's a safe tube of bone that will accommodate our screw and put our screws in. And then once these are done, or in the process, going back and forth between putting in bone anchors, we'll do these releases and osteotomies. And on the left side, there is a sort of a sawbones picture of what we might call a ponte or a posterior column osteotomy, where all the bone between each of these two levels is removed. You can see here on the right side, it's more of a cartoon diagram where this V-shaped segment here of bone and ligamentous tissue is removed, leaving only this yellow spinal cord and the nerve roots. And that allows for some more flexibility of the spine and oftentimes more safety as we do manipulations to straighten the spine. Next, we'll select and contour our rods, and this can be surgeon dependent as there are many different techniques, but suffice it to say we typically select two rods. Sometimes we contour them differently. Sometimes they're very similar depending on the patient's deformity. And then we apply the rods to the screws. You can see here on the left, these screws, the pedicle screws will have a channel in the center, we call it a tulip, where the rod sits very nicely. And then we apply another set screw on top to hold the rod in place to the pedicle screw bone anchor. And then we can apply different types of corrective maneuvers. You can see here we have compression and distraction. You can imagine these two levers here are distracting or stretching the space between these two in the center, on the center film. Or on the right, there's compression, where the compressive forces are shortening the distance between these two screws. Here's just another sawbones example of how one might have these rods. Here you can see at the very end, at the foot, and the top of the head, they're connected, and they're not yet seated on these other screws in the middle. And we use a series of these instruments that are usually threaded to allow gradual, safe correction and bringing the spine to the rod or vice versa. There's a lot of different techniques. There's just one more slide depicting that. And here's another example of correcting the patient's rotational deformities, as the rib humps are basically produced by rotation of the bones in the spine. So there are tubes like this that are used to help derotate the spine in clusters. You can see they're clamped together to provide load distribution so that the forces are distributed, and it's much more safe distributing the loads over many levels. So these are just some of the techniques that we'll use to create the correction. And when it's all done, it looks something like this. Patient's head is on the right, the patient's foot is on the left. You can see the two rods are in place. Once the rods are in place, then that central area, we fill it with bone graft, and that can be obtained from different places. I think most try and use bone just from the patient, him or herself. It can be used from the bone that was taken from the releases. We can be augmented with some bone extenders with bone marrow. But suffice it to say, this is a very important part of the procedure because this is where we get our fusion, which provides the lasting effect of the surgery. And then it's usually closed with a running suture and looks something like this months down the road when the patient is healed. The post-op protocol is different, and I would tell anyone out here listening that your surgeon's post-operative protocol is best for you. It's very variable, but most have a few days stay in the hospital for pain control. All centers that do this have a very aggressive pain regimen because the surgery does hurt, and the patients will do better and feel better because if they don't hurt as much, they're going to get up and move more, which is very important. After surgery, patients get up and become mobilized. Most are out of bed the day of surgery, if not the next day. And there are activity restrictions afterwards based on, again, the surgeon's preference, and it's usually on the order of months as far as activities, what patients can return to as far as sports and things like that. But the vast majority are ultimately able to go back to their previous level of activity after they're done with their procedure in their appropriate time window. And that's what I have for surgical techniques.
Great. Thank you, Dr. Goodwin, for the excellent overview of surgical techniques. Next, we have some case presentations lined up, and these are professional opinions only and not meant as prescriptions for treatment. As you've heard throughout the talks, each situation is unique, and you should consult your own spine specialist to discuss your specific case and treatment options. So having said that, let's start off with the first case with Dr. Goodwin. And he'll give you a brief overview of one of his patients. So
here's just a case example of someone with idiopathic scoliosis. This on the right is an X-ray of a 15-year-old girl. She was followed for quite a while with a curve in her back. She has no pain with this whatsoever, and she's very active in competitive cheerleading. That's her passion in life at age 15. She has what we call true idiopathic scoliosis, meaning we don't know the cause, but she has no other reason to have scoliosis. She was treated with a brace for a while, but despite that, her curve got worse, and both her mom and herself were very concerned about the bumps being there on her back and concerned about the way it looked and the possibility of what might happen later in life, as Dr. Neal has discussed. At this point in her life, her skeleton was mature, and one of her goals was she wanted to be able to continue her competitive cheerleading. And this is what she looked like. Again, her x-rays are on the left side. This is her standing up x-ray. You can see her curvature, which measured, this one measured around 50 degrees, or slightly over 50 degrees. And this is what she looked at like from the side. And one of the things that we'll use to determine surgical planning is how flexible the spine is. You can see on the right side here, these are bending x-rays showing how flexible her curve was. Her lower curve was very flexible, and the upper curve was fairly flexible as well, but not as much. So she elected to undergo what we would call a selective thoracic fusion, meaning a fusion of just the one curve, and went very smoothly. She was in the hospital about 3 days. She didn't require any blood transfusion. She was back to school in 3 weeks, and ultimately, after her very patient period of time, she was back to cheerleading and tumbling by about 6 months post-op. And you can see this is what the bone anchors that we used, and all of those elements that I discussed in my talk, we used to make the corrections, not only looking at her from the front, but also the side and rotationally to help eliminate her rib humps, or make them smaller, I should say.
Thank you for your patience. I'm going to talk about a slightly older person who had scoliosis at age 13. This is a girl who was diagnosed with scoliosis at age 13. There was no family history of scoliosis, which is very typical. She was treated with a brace, but her curve gradually worsened, and she was complaining of some back discomfort. Typically, scoliosis is not painful, but some patients can get muscular aches and discomfort from the curvature of their spine. These are her x-rays, and you can see she was measured to have an approximately 45-degree curve, which, as you understood from the talks earlier, puts her in the category of benefiting from scoliosis surgery. She underwent a posteriorly based fusion, did not require transfusion, was hospitalized for 3 days. Her x-rays before and after, and you can see the correction that was achieved, and this was the incision that we used for her surgery. Postoperatively, she has gone back to all her activities with no limitations at this point. Well, thank you all for being patient through the talk, and now we'll just go through the list of questions that have come up through the talk, and certainly if you have any other questions that come up, feel free to send it on to us. So the first question that we'd like to tackle is about MIS surgeries and centers that do these kind of surgeries around the world. Maybe I'll direct this to Dr. Goodwin. Any thoughts on MIS surgery and any resources for our patients to look into when they're researching scoliosis surgery?
So the question is about MIS surgery and how does minimally invasive surgery play in for idiopathic scoliosis, and what resources are available. Certainly, there are some techniques that have been used for minimally invasive scoliosis surgery. Again, they're probably not as prominent as the traditional open surgery, and I think, personally, I have used the techniques a couple of times, but I still prefer the open technique, because I think the most important part is getting the fusion. So whether this is done minimally invasively versus done through a more open incision, the most important part is to obtain the fusion. So I would advise you each to talk to individual surgeons. The Scoliosis Research Society website I often refer my patients to, because I think it has the largest set of page for information for patients that is based on science. So I guess the short answer to the question is there are techniques that can be used that are minimally invasive. They still involve incisions, they still involve a fusion, and they still involve instrumentation. So I would urge you to have a frank conversation with your surgeon about what techniques are best in his or her hands for the patient.
And sort of a follow-up question to that for Dr. Goodwin. There's also been a few questions on VBT. So can you define that a little bit, and how did that differentiate from MIS for a lot of patients? There may be some confusion about those terms.
Sure. So when MIS, we're thinking of a minimally invasive surgery, which usually implies minimal incisions or smaller incisions, or some sort of scope type procedures or thoracoscopy, which would lead into VBT, or vertebral body tethering, which is a much newer technology that is starting to gain some support with evidence, although it's very, very new. The concept of tethering is different. In our webinar here, we've been speaking about fusion surgery, where we're getting the spine to fuse in a corrected position, whereas vertebral body tethering is usually done as a procedure in the chest, where the spine is tethered, if you will, with implants to modify growth. So it is not a fusion operation, and that can be an option for a very small subset of patients. And I think as a society, as the Scoliosis Research Society, we're still starting to define the indications for this and which patients it may work best for, because there really is not a lot of long-term evidence yet. But there are centers that are performing this safely in a certain select group of patients.
Great, thank you for answering that, Dr. Goodwin. And to the person who posted the question about centers in the UK, the society as a whole does not specifically list centers where these are performed, and you may have to go online and do your own research. The SRS website is a good resource to find surgeons that perform scoliosis surgeries in your community, and then you can call them directly to find out if they offer that technology. We're not very specific about who might offer this in the UK. Next question is maybe for Dr. Neal. There's a question about an S-shaped curve, and when surgery is done, is it just done on the top curve? And if so, how does the bottom curve correct?
That's a great question. Thanks, Sanjeev. So scoliosis can come in several different varieties, and when we're trying to classify scoliosis, we really think that most patients have 3 curves in their spine. So They have one in the upper part of the thoracic spine. They have one in the main part of the thoracic spine. And then they probably have some curvature in the lower part, which is called the lumbar or the thoracolumbar spine. Now, scoliosis surgery has several goals, but they include preventing future progression of the curve, but also achieving good balance of the spine, and also fusing as few segments of the spine as possible. And that's because when we fuse segments of the spine, we think that we're going to put additional stress on the lower segments that haven't been fused. And if we leave a lot of segments in the lower part of the spine, we think this is not a huge problem going forward, but if we go down too far, we think we're going to place a lot of pressure on a few motion segments, and that might lead to changes later in life, such as degeneration or arthritis. So the question is, how do we decide to just fuse one curve versus fusing both curves? We take special x-rays before surgery that can tell us how well the curves bend, which tells us about their flexibility. And so we're more likely to be able to do just one curve instead of both curves if the other curve is very flexible. We also need to look at the x-rays and see how much the patient's body is shifted to one side or another. And so in patients where there is not a lot of shift of the lumbar curve to one side, we're more likely to be able to just do the thoracic curve. But in patients where the lower curve is shifted markedly to one side or another, we are less likely. Thanks.
Question for Dr. Neal. In his talk, he mentioned about small curves versus large curves, and maybe you can clarify what do you mean by a small curve versus a large curve? And there's some other questions about bracing I'll ask right after that.
Okay, that sounds fine. And so the important thing to remember is that these numbers are not absolute, and as I showed in one of the earlier slides in my talk, there's always some measurement error when we're talking about these curves, say plus or minus 5 degrees either way. In a very general way, what we can say about the natural history is that patients who finish their growth and they end up with a curve that's less than about 40 degrees, those patients are very likely to do well. And what I mean by doing well is their curves are very unlikely to progress in the future, and the curves are not likely to give them any adverse effects. They don't cause an increased risk of injury. Patients are not more likely to have back pain compared to the general population when the curves are smaller. Patients are not more likely to have degeneration compared to the general population when curves are smaller. When curves get larger than 50 degrees, we're fairly sure that those are going to progress slowly in most patients, and so their natural history is different, and that's why we start recommending surgery at those levels, because most patients don't want them to continue getting worse. 40 to 50 degrees is a bit of a gray area. We just don't have a great crystal ball on that population. And so if you have a curve in that range, basically what we do is we ask you how you feel about your back. And so patients can tell us, well, I already hate it, and I don't like the way my back looks, and I don't like the way my back feels, and I definitely don't want it to get worse. And so I want to think about stopping it and stabilizing it with surgery now. Or they can tell us, I'm fine with my back, it doesn't bother me, I don't really notice the bumps, and I'm willing to just keep an eye on it and see what happens.
Okay, great. Thank you, Dr. Neal, for that. Maybe I'll have Dr. Lee answer some questions about bracing. There are several sort of related questions about bracing. The first is how soon after the brace, after getting the brace, should an in-brace X-ray be taken so that you know the brace is doing something? And how much correction in a brace are you supposed to get, and so you know that the brace is working properly?
Thank you, Sanjeev. I think the first question is, how soon after you get the brace should a brace X-ray be taken? Typically, the brace X-ray will be taken 1 to 2 weeks after the brace is applied, simply to check to make sure that everything's being pressed on in the correct way. You want it done quickly so that you can modify the brace and make sure that the kind of treatment course is appropriate. meaning that the brace is working as you had planned. The second question is, how much correction do you need in the brace in order to make sure that it's working correctly? I think it depends on the type of brace that you're getting, and we know that there are a bunch of braces out there. In general, for the typical full-time or nighttime braces, the radiographic correction should be around 50 to 70%. I think a lot of orthotists prefer to kind of see somewhere around 70 to 80% ideally, but that has to do with how flexible your curves are. We believe a brace is effective if you get at least 50% correction of your pre-existing scoliosis.
Great. Thank you, Dr. Lee. And so somewhat related to that, can you have surgery if you're still growing, and how does surgery affect growth? This could actually be something that can be opened up to all the presenters in terms of if you have surgery, can you have surgery if you're still growing, and how does surgery affect growth of the spine?
Can you have surgery if you're still growing? The short answer is yes, but it always involves magnitudes. So if you're growing a ton, you can't really have the surgeries that we talked about here, meaning a strictly posterior spinal fusion. We worry that once we lock down the back of the spine, the front of the spine will keep growing. And in those cases, your curve can actually come back. So if you're growing a ton, for example, if you're a girl and you haven't started your periods yet, if you're a boy and you're quite young, and we consider like a 12 or 13-year-old boy kind of fairly young, we try to wait until your major growth cycle is done. And we know that by just kind of calculating your height and measuring your height and just kind of seeing where you are in the growth cycle. I think that was the kind of growth question. I don't know if Dr. Neal and Dr. Goodwin have a comment about that.
Sure, I think that was a good explanation of Dr. Lee. In very young patients, we don't want to limit the growth of the spine, because if we limit the growth of the spine, it limits the growth of the lungs. And so in really young patients with scoliosis, we're using other techniques. There are instruments available that can grow with the spine, but they're generally not used in adolescent idiopathic scoliosis. So when we're talking specifically about adolescent idiopathic scoliosis, we're by definition getting to an older age where patients are getting close to the adolescent growth spurt and therefore close to being done growing. We look at radiographic markers on the scoliosis x-ray, and some surgeons will also take an x-ray of your hand to look at your growth plates and see how much growth you have left. And we can kind of tell from those if we have too much growth remaining and you need to wait, or if it's safe for you to go ahead. And in most cases in this age population, you're already at a point where it's safe for you to go ahead. But because chronological age is not a perfect marker of how much growth you have left, you need to have your surgeon look at those factors and decide.
I will oftentimes tell patients, look, whatever part of the spine is fused won't grow anymore, and the part that's not fused will continue to grow just like the rest of them, their arms and legs and everything else. And it's important, it becomes too young, because again, we're trying to get patients, grown up enough to basically accommodate an adult lung chest cage. So if the patient is large enough or close to large enough to be able to support adult lungs, then they're usually old enough to have surgery if the curve is bad enough. And certainly waiting is usually an option if you're not sure.
It's interesting. A common question asked by parents and patients are, if you fuse my spine, I'm going to stop growing, so I'm going to be really short. But that's actually not the case. If you look at two copies of yourself, one where you don't get the surgery and the other one where you do get the surgery, you actually wind up taller in the future if you do get the surgery, because the surgery adds height to you. If you allow the curve to progress, you actually shrink a little bit over time. So it's an interesting kind of thought, and it's an interesting side benefit of the surgery.
Great, thanks to all of you. I think there's just time enough for a couple more questions, so I'll try and get through the most pressing ones. An interesting one was about the complications and what % of problems that arise in patients after surgery. Any thoughts on that? Maybe all panelists can give a brief answer to that.
We look at all this quite routinely, and we look at thousands of patients literally to find the complication rates. And I think you can define complications several ways. If you say the risk of having to go back to surgery after your first surgery, we can say that in your lifetime, in the time after you receive the surgery, it's probably about 5%. And this is inclusive of everything, including infection, need to go back to revise the hardware, late infection, possible late neurologic complications. I think the complications that patients worry about most, these are infection as well as neurologic injury in the acute setting, meaning early on after the surgery. And for that, we have kind of pretty good numbers. We say that neurologic injury complication rates are about 0.5% in large studies, and infection rates globally, I think nationally, are about 1%.
Yeah, and I'd just like to add that that's one reason why Scoliosis Research Society is a great organization, is because they are able to pool data from all of their members about complication rates so that we have a better understanding of this. And I don't have much else to add. Infection is by far the most complication, the most common complication, and it's considered to be about 1% in most centers.
Yeah, again, not much else to add. The two things that concern families the most, again, are infection and some sort of catastrophic neurologic process, which fortunately with our monitoring and our modern techniques is extremely uncommon. I still worry about it every time. We do lots of things to prevent them, but infection and neuro are the two probably most common or most feared complication by patients and probably by treating physicians as well. But again, the Scoliosis Research Society, as Dr. Neal pointed out, we're very fortunate to have pooled data on these complications and can monitor them and figure out new ways to even lower the rates.
Okay, great. We're over time, but maybe we'll just answer one final question. To all the participants whose questions we couldn't get to, we'll certainly, the webinar will be posted online in the SRS patients and families section. And there'll be a link where you can certainly send your questions, and the link will be open for an additional week, and we'll certainly try and answer all the questions that we weren't able to get through today as well. So thank you all for participating. The last, maybe we can talk finally about rehab and return to activities after surgery, because that seems to be a common question as well. What to expect after scoliosis surgery.
Dr. Goodwin talked a little bit about post-operative protocols in his talk, and I'd like to say that you're going to have to talk with your individual surgeon about your particular surgery and what's going to be expected. What I can say is that over the last several decades, the protocols have become much more advanced, and in general, patients are getting out of the hospital faster and they're getting back to activities much quicker than they used to. So for my practice, the averages are that you're going to be with us in the hospital for a few days. We're going to let you go home from the hospital when you can do normal daily activities of normal daily living, which means you can eat and drink and walk and go to the bathroom and climb stairs if you need to and get yourself in and out of bed, and your pain is adequately controlled. It takes a few days to accomplish that in most cases. You're going to need some pain medication when you go home. You can't go back to school until you're off of pain medication, narcotic pain medication, but that's kind of my threshold for going back to school. I hope to get most patients off of their narcotics 1 to 2 weeks after surgery, and I hope to allow them to return to school 2 to 3 weeks after their surgery. I generally limit rough activities, which includes heavy book bags or sports, etc., for at least a few months after surgery, and then I'm kind of conservative on the really rough stuff, collision sports like football or ice hockey, or riding roller coasters, and I tend to not let my patients do those really rough things for 6 months after surgery, but you'll find different protocols from other surgeons.
Yeah, I would agree with Dr. Neal. He's spot on on the sort of goal-oriented activities. You know, you're in the hospital until you feel better, you can take care of yourself, back to school when you're off pain medications. And for me as well, the rough activities like sports, tumbling, collision sports like tackle football, I usually recommend not going back to, but pretty much anything else. Roller coasters here in Cleveland, we're about an hour away from one of the biggest roller coaster parks in the country, and they all want to know when they can go back there, and that's usually about 6 months. And it also depends on what activity you want to go back to. Like the case example I showed you with the tumbler, she had a fusion down to L1. So someone who's got their lumbar spine spared and a fusion in their thoracic spine is going to have a much better time going back to doing tumbling or gymnastics And say someone who has a fusion of both curves and their lumbar spine is included, their advice even before surgery is that you probably will have a hard time getting back to one of those activities with a longer segment fusion. But ultimately, after 6 months, in my practice, I let pretty much everyone go back to what they'd like to do unless there's a problem.
I agree with Dr. Neal and Dr. Goodwin, and it's amazing. Despite our geographic divide, we have very, very similar protocols. I think the only thing that I would add is, I get a question quite a bit from parents about physical therapy, and I think for a lot of orthopedic procedures, you need physical therapy after. I think for this, if you're working on a teenage population, otherwise healthy, I almost never sense a physical therapy, and it's not part of the postoperative regimen.
I would agree 100%, and I get asked every time, when do they start therapy? And I say, well, the answer is they don't have to, because we're really waiting for the fusion to happen. You don't need to stress them any more than they're already going to do living their life. So if they want to, maybe by a few months in, start some light core exercises or some stretching, I'm fine with that. But really, it's the limitation of the impact, the running, jumping, pounding, that is probably most important to help the fusion solidify. And so therapy really is often not needed.
Great, and that's all the time we have allocated this morning. So thank you all to our esteemed speakers, presenters, as well as our participants. This webinar was meant to be an informational guide and evidence-based outcomes, and you can find additional information on the SRS website where you can search for physicians, as well as the latest research on scoliosis.